Now you got to prepare your voice.
I'll prepare my voice.
Unique New York. The
Ugh.
arsonist has oddly shaped feet.
I would hate to see your search history of how you come up with this stuff.
Just watch a lot of shitty movies.
I'm sure your wife is like, shut up, James.
Yeah, I get a lot of it at home for sure. Okay.
All right.
So we're recording here, we're recording there, and we're ready for another journal club. Anything particular that you, any like cold open that you want to do? Anything you want to say?
No, I think let's just do it.
This is going to be a cheeky one.
Hot take.
Do you get it? It's going to be a cheeky one.
James, I'm trying not to laugh at you.
I like your title of this. You submitted me this title for this journal club: Fingers and Tubes and All Orifices, Time to Rethink.
Yeah. You've never heard that?
I feel like I'm of a vintage that
That used to be in every emergency medicine, critical care, and ATLS textbook.
all right, let's tell them why this is time to close the case on this one.
All right, James, let's give you a little case to start. 19-year-old motorcycle. He's going down Quimpool. Car pulls out in front of him. It's a guy, and he slides off his motorcycle. He's pretty close to your hospital, so they bring him in for assessment just on mechanism. He's hemodynamically stable. He's wide awake. He's boarded and collared. Paramedics have not identified any injuries.
Okay.
You go through your primary survey. He's alert, talking GCS 15. He's just kind of scared. Can't find anything on your primary survey. The team rolls him over to do palpate the patient's back, and they don't find anything. And you see the surgery resident don their glove, find
I know where this is going.
find some muco, and start walking towards the patient, and says to the patient, "I need to check your rectum." And the patient starts yelling, "No."
I
What?
tackle the resident.
Really?
I take
We
security
have to discuss that later.
security to room 12. Get this resident out of here.
Okay. Why?
Oh my gosh. I can say, I preface this, so I came with a vintage of, we didn't really do that many rectal exams. I think probably because, I was
I trained
educated
you.
under. You trained me. Yeah, exactly. Exactly. So I came from the school of no rectal exams.
Yeah.
And I think, that clearly I know that has been historically the case, that all these patients got examined in a primary survey and that ended with having a rectal exam to check tone, many other different reasons we'll, I'm sure, get into. And I've seen a few of them done, and I can say that anecdotally I have not seen one rectal exam ever contribute to patient care, ever contribute to a change in the patient's trajectory or disposition.
Okay, let's stop. We're done.
Okay.
No, we need to talk about this because I can tell you, even now, in a lot of centers across North America and U.S. and Canada, across the world, that rectal exams, your digital rectal exam DRE, is part of the standard approach to trauma. In fact, in the most latest edition of ATLS, it's still recommended in select patients.
Wow.
Yeah. So we want to talk about that because when I became senior medical director for the trauma program, I've attempted, done as much as I can to stop the practice of digital rectal exam, but I still see it attempted while we're resuscitating patients. And I think we need to look at the evidence, which is why I think we should take a look at this article. To your point of fingers and tubes and all orifices, well, that used to be part of a standard line in emergency medicine textbooks, critical care textbooks, surgical textbooks in ATLS.
Mm.
And it is definitely time to rethink. And I want to go through this study
Okay.
and get your thoughts on it. But I think, James, you've been trained not to do this. So
Let's hear about this. This is a systematic review.
yeah, this is a systematic review from Beaton et al. Entitled "The Benefits of the Clinical Application of the Digital Rectal Exam in Trauma Populations Towards Enhancing Patient Safety and Quality Outcomes." It was published in 2022 in the American Journal of Emergency Medicine. And I'm just going to read one of their first lines, which I don't think I could summarize any better. Recommended by the American College of Surgeons Advanced Trauma Life Support course. The DRE's intention is to assist for a declassed or absent rectal tone, gross blood, a high riding prostate, bony fragments, or the disruption of the rectal wall. These findings can act as positive and negative indicators that can assist physicians in determining whether a spinal cord injury, urethral disruption, or pelvic fracture has occurred. However, while recommended by ATLS, this examination has received infrequent support throughout the emergency medicine community, as it is highly uncomfortable for the patient, easily misinterpreted, and potentially unreliable.
Nice. Well said.
I really think they've done it well. So they did this study, and it's a systematic review of the literature. They had 2 PICO questions. In adults and pediatric trauma patients, what is the sensitivity of the DRE for detecting spinal cord, GI, or urethral injuries? And does it change the treatment? They searched the literature up until 2022 and came out with 9 studies. Their only exclusion criteria was non-English papers, so this is just English. So 9 studies, only one of which were prospective. They range from 41 to 1,400 patients and a total of 3,775 patients. 2 of the patients included pediatrics. Otherwise, they were all adults. Okay. Their main outcome was a sensitivity of 7 to 51%.
Doesn't sound good.
No,
Flip of a coin.
That is not good. So what does sensitivity tell you, James?
So spin and snout. Specificity rules it in. Sensitivity rules it out.
Right. So if you have a test that has high sensitivity and it's a negative test, then it essentially rules it out. In this study, the best it performs for ruling out injuries is 50%.
Flip of a coin. Is that kind of,
and probably less than a flip of a coin. So if you have a 4-sided coin,
you might as well just flip the coin.
just throw it at the wall.
Got it.
It was same in adults and pediatrics. And when they subdivided it out in GI injuries, urethral injuries, and in pediatrics, no change, all less than 50%. In their conclusion, the digital rectal exam was consistently worse in detecting injuries than other clinical indicators, and it did not alter the next steps in the management of the majority of traumatic injuries.
They must have looked at specificity as well, did they? Or maybe that's been shown in another study.
So they didn't. But they did compare everything to a CT scan.
Sure.
Right. To all the studies, and that was one of the criteria, is they had to compare the test to the gold standard.
Got it.
So that, to me, takes the world's literature, puts it in one paper, and certainly aligns with my practice and my bias. So I absolutely love it. And I want your opinion on that, James. Does this change your practice? What do you think of the study? And are you going to do a digital rectal exam in any trauma patient as part of your resuscitation?
To answer the last bit, I would say no, at least not in the primary survey.
Sure.
And I'll expand on that. So this is not going to change my practice because my practice is already that I don't do these. I think it adds and supports what I'm currently doing and gives me a bit of arsenal to say this is why I'm not doing it. The thing that I think is really important to recognize is, so why, beyond spinal cord injury, some of the other reasons, and you talked about them as to why you might want to do this, there probably is utility to assess for open fractures, something that could get maybe missed on CT, right? Like doing a rectal exam to see whether or not there's any sort of intraanal or rectal perforation from a pelvic fracture, maybe.
Have you heard of that?
Have I ever seen it? No. Have
No.
I heard of it? It happens. It's listed as the reasons why they might want to do it.
Sure, but it doesn't actually rule it out.
Sure.
Right?
Yeah, for sure.
So I get it.
I guess I'd want to know specificity, though, right? Because if you did it and it's there, then it's there. In terms of ruling it out is one thing, but if you did it and it was present, then
The question is, are your other tests going to be better at it?
Sure.
And in this case, your other tests are better.
Yeah.
Right?
Yeah. No, fair enough. Bottom line, if you, and there is pun intended there on the bottom line, got it?
That's cheeky.
Yeah, I don't want to be too anal about this, but
I knew you couldn't do this.
I'm not mature enough for this topic. So, look, but in all seriousness, even if there was reasons why this is important from other services, like if they could conceive a reason why it would be important to do this exam, there is zero reason for it ever to be done in the primary assessment, not only because it's not clinically relevant, but the amount of indignity that this would cause to a patient who's already had their dignity taken away with what we do, right? Think about it. Like, patients come in, that one you described, even though he's not very sick, we're going to undress this person in front of a whole bunch of people in a big open room.
Yeah.
And, that is a loss of dignity, despite that we're just trying to do the right thing. And then if you do an unnecessary thing that invasive, unnecessary thing that goes even, takes the indignity even farther, I just think that's inappropriate. If it needs to be done, I think when it needs to be done is with the person that thinks it's going to change your management, with one other person as a chaperone in a room with the blinds closed and privacy and a bit of dignity. If they think that it's going to change management, it's still probably not going to.
100%.
Yeah.
So I think one of the reasons we do this podcast is to not only talk about fancy things in trauma like ROBOAs and delayed sequence intubation and blood product use, but it's the low-hanging fruit of things that are still being done in trauma care in Nova Scotia and Prince Edward Island, across Canada, that we should say, okay, let's reevaluate that. You don't need to be doing that. In fact, I don't want to have any of our trauma patients in Nova Scotia have a digital rectal exam as part of their primary, even part of their secondary survey, while they're referring in to us. Unless there is a specific indication for it, it should not routinely be done.
Yeah, good summary. All right. We'll wrap that one. That's a wrap. Thanks for listening. For more free open access trauma-related content, subscribe to Trauming on Apple Podcasts or wherever you get your podcasts, or tune in to us at www.trauma-ing.com. Thanks, guys.